Hi, everybody. This is Susan Clinton, one of your co-hosts of Tough to Treat, and this is episode number 165. I just wanted to pop in and welcome everybody back to Tough to Treat. We have an interesting case. We don't usually talk about the shoulder and the wrist and the hand as much, but I thought we would bring this one in. And I just wanted to remind everybody that join us on our website, www.toughtotreat.com. And if you haven't had an opportunity to leave us a review, please do so. It really helps everybody find us. Thank you so much. Enjoy the podcast. Hi, everybody. Welcome to podcast number 165. This is Susan Clinton, one of your co-hosts, and I'm here with my fellow co-host, Erica Mello. How are you, Erica?
I am fine, Susan. How are you?
Good. At the time you all will be listening to this, it will be mid-June, and we're hoping everybody is having a pleasant and wonderful summer. So shall we get right to it?
Let's do it.
All right. So as I said in the intro, we don't really usually talk about this relationship of the hand and the shoulder. So I'm kind of giving away the story before we even start, but I'll just kind of get rolling with it. The client that I had was a body worker, and she'd had right shoulder pain that had been progressing over the years, just, how that goes. And she's now in her late 40s. And she's experiencing sharp pain when her arm comes into abduction and internal rotation. And then, of course, horizontal adduction makes it worse. She has full range of motion. She's doesn't have like limitations. She doesn't have any night pain. She doesn't have inflammatory responses. I looked through all of those things thinking, here we are, late 40s.
Right.
Could be a frozen shoulder type situation kind of coming on. It is not a capsular pattern. So we could rule a lot of that out just by kind of, talking and figuring some things out. Just looking at her, I just did palpation first for whatever reason. I just did because she was showing me where it hurt. She did have some tenderness over the long head of the biceps tendon, and she did have some tenderness in between and onto the coracoid process. So it kind of makes you think, oh, it must be an inflammatory or a tendonitis of the biceps, right?
Right. Yeah.
So, but it could also just be from, how she's using her arm and the mechanics of what she's doing. Looking at her scapulas, they're both slightly winged and downwardly rotated, which kind of got me looking at her thorax, which meant her thorax was a bit stiff in the center.
Yeah.
And at the cervical thoracic juncture. Yeah. Not atypical of what you would find with this. She is on the thinner side and the more hypermobile side. So kind of keep that in mind too, which is again why I kind of kept backed up and started looking at all those. There are any kind of red flags here that we need to be paying attention to. Yes. Asked her about, just other things about her. She had any recent blood work? Is everything okay? Everything was fine. There wasn't really anything out of the ordinary. It just, because of the work she does, it just hurts. And now it's hurting away from doing the work. So, yes. You put up with things until you can't put up with them anymore. Right. And then,
exactly.
And then it drives you in to kind of come and see about it and see what you can do about it. The interesting thing was, right away I got under her scapulas and did a little lift on them, had her move her arm back into the position. It felt a little bit better. But then she started telling me about, well, my hands hurt too. So I thought, well, we better go take a look. So elbows are fine. Long story short, elbows are fine. Wrists were stiff to extension. On the right side, she had a lot of pain on her CMC joint of her thumb. Not atypical for all of us physical therapists and body workers and people who are always putting their hands on the bodies. She also had some thickening of the PIP and DIP joints. So there's got to be a little inflammatory something going on in there, because we all know that the early stages of OA is inflammatory. So her neck was unremarkable. I decided I better go and look at this whole complex. It's like, okay, this is more than just a little shoulder pain. This is starting to look like a whole right upper extremity complex. Let me see what's going on here. So the neck was completely unremarkable. Didn't bring on any symptoms. Everything was fine. Moved well.
Okay.
Didn't increase her shoulder pain in any way. Her neuroscan was completely unremarkable. I did a full, dermatome, myotome,
reflex,
all of that testing. And then the special tests, obviously the NIRS is positive.
Yes.
Reaching across the body and internal rotation. But and the crank test of the CMC was positive. So pressing and cranking that CMC joint did not feel good.
Right.
So so I'm kind of looking at this going, we kind of have two problems here. We've got a little bit of this thumb wrist problem, and we've got this shoulder problem. So I went back up to her thorax and, again, got underneath the scapulas, but this time on the right one, I really, did like the one you talk about where you scoop up underneath the inferior angle.
Yeah.
And I brought her into some upward rotation and unloaded. Didn't even mess with the left one. I just thought, let's just go with this one and see what happens. Yeah. And she was able to come across her body with much less symptoms. The obvious thing is like, let's tape it. So I'm smiling because I'm thinking something I don't know, something isn't right here. I just had that kind of feeling like, okay, this is just, and not that everything can't be simple. Obviously I can help her mobilize her shoulder. I can teach her how to deep friction over her tendon if she wants to. I mean, we can do that stuff. That wasn't worrying me. What I was trying to figure out was how to get her out of symptoms so she could work.
Right.
Go ahead. I was going to ask you for your thoughts.
So this was so I'm assuming she's right hand dominant, right?
Yeah.
And so she had any other injuries before or any other issues before this, like in her history? So this was the first time. Okay.
Yeah, nothing. She's had bumps and bruises and things, but never anything that she had to seek out medical attention for. Anything that was remarkable in any way.
Okay. And then besides her body working profession, does she do any other sort of movement, like any specific sport? She's not a sports person. She likes to walk and hike. Okay.
But again, no injuries, lower extremity, knee, hip, back.
Got it.
She's always felt good, which was why she put up with this, because she just thought it was going to go away, and it just kept getting worse and worse and worse.
I know. And is she always on the same side of the table when she works?
That was a great question. That was going to my next question too.
Okay.
Tell me,
perfect.
We're going to dig into the occupation here, because this is where it started. Now it bothers her in all kinds of positions, but this is where it started. And so I did ask her that. I said, tell me about your work. And we talked a lot about what she did. And what bothers her the most is when she would like pick up a limb, like a leg, to stretch it. That bothers her. When she digs into tissue, it bothers her in the shoulder. And then I asked her that question. I said, which side of the table do you work from? And then she kind of sat there for a minute. I said, which side of the table do you work from the most? And she said, oh yeah, because I do go around to the other side of the table. But for the most side, she works on it would be where her right side is closest to the table.
Yes.
Yeah. Which makes sense, right?
Yes.
In some ways it makes sense. So I asked her, I said, just show me, let's do this. So we put some pillows down, and I said, dig in like this is a person, and like doing whatever it is that you do. And so she goes into this thing where she leans forward and she does abduct and internally rotate her shoulder to push straight down into the body, for like connective tissue massage type of thing. And that fires off the pain in her shoulder. So because I'm still thinking I'm going to taper. I'm still thinking I'm going to taper, So I don't know why I didn't taper, because that was what I was going to do, and send her home with a couple of reset, try to find a couple of reset exercises and that she can do in between, so that she can rest this arm, between work. And we, and I was going to talk to her about the left side of the body or the left side of the table. but something about that position just really bothered me. It was like, why is she getting herself in that position? And I said, so I asked her, I just said, why are you doing that with your arm? And she said, well, I need to have pressure to go down into the body. I said, okay. I'm wondering if that's the only way you can generate pressure.
Can she raise and lower the table? Or no, she has a massage table. Right?
Yeah, she can't. Yeah, she doesn't have that. Yeah, she doesn't have that thing.
Got it.
And she doesn't want to stand on a stool because she feels like, she doesn't
Yeah,
have great. She feels unwieldy up there.
Yeah.
But it was interesting because I asked her about it and I said, so what if you just for kicks and grins, drop your elbow down and do the technique for me? And the shoulder was fine, but the thumb was not.
God,
the thumb was exquisitely painful. And I don't, and it was like, it was almost like lightning bolts went off, and it was like, so how are you aware of, kind of what's going on here? I just wanted, I wanted to hear her thoughts. I said, did you used to work this way? And it's been years. Like this has been an adaptation she's created over years, not just like something that happened 3 months ago. Yes. And, it was really interesting because in sitting down and talking about it and breaking it down, we kind of figured out what happened was she started developing this pain in her thumb. And because there's no way she could continue her work with the pain in the base of the thumb and at the base of the wrist, that kind of pain, it was debilitating. It hurt too bad to even continue to do the work in the moment.
Right.
So so we discussed it, and what she had done is develop probably this adaptation over time, where if she was straight up onto it, she could do it. Yeah. But if there was any kind of twisting that went on in the thumb from that, position with her elbow in, she couldn't, the forces were too different and it hurt. So she had developed this issue in her joints of her hand, her right hand. And she used the shoulder position to alleviate it.
I was just going to say she raised her elbow just to get her thumb off into a better position. Yeah, it's interesting.
So
I'm sure I do that too when I work with patients, I'll be more mindful of that next time.
It's pretty interesting though, because if I had taped her, she wouldn't have been able to work. She would have taken the tape off because it would have been, it just wasn't going to work.
Yeah. She had no options for movement at that point that were helpful for her. Yeah.
So what I did was I taught her how to tape her wrist. What we did was we did a split V coming from the wrist point, from above. So if you're looking at, let me see if I can get the landmarks right here for everybody. All right, if you're looking at the joint of the base of the thumb as it articulates with the wrist on the medial side, like on the inside. Yeah. This joint right here where the thumb comes down and meets the wrist on the I guess it's the lateral side of the hand when you turn the hand over, whatever.
Right.
Yeah. So I go above that into a little bit of the flesh of the thenar eminence and create the point of the V. And then I bring the tape down towards the middle of the forearm, and then I bring the tape back towards the middle of the dorsal part of the forearm.
So I'm just thinking I have my hand in front. So it's almost like you're unloading the thenar eminence like you would have unloaded the scapula. It's almost like you did a V sling.
Yeah, exactly. So we're V-slinging down towards the forearm, one towards the volar surface and one towards the dorsal surface, about halfway. And we tried and played around. It still bothered her at her CMC joint. So what we did was just a figure 8. We cut the tape in half. And for this, I used kinesio tape for this because, she needed to move her hand. The leuco tape wasn't going to do it. And it doesn't really matter how you do the figure 8. You can do one side of the figure 8 and then another side of the figure 8. All I was doing was trying to give her a little sensory input for perceived support for her thumb. My hypothesis here is that the thenar eminence had become over-recruiting. And so a myalgia tension, in the thenar eminence that was keeping that joint pulled into a funny position. So I was trying to just open things out a little bit for her so that she could actually see if she could get more, like if you take your hand and you're going to put it around a glass of water Just think about what it has to do. It needs to open first, and then it kind of closes around the glass.
Yeah.
She wasn't in a good position to do that. She had kind of caved in a little bit at the base of her thumb and at the base of where the metacarpal attaches to the wrist.
Yes.
And so basically, and that hyperthenar eminence was pulling all the time. So if you grab your your thenar eminence, if you grab it and squeeze it, you'll see what happens to your hand immediately. It like pulls that joint down, into that position when you pull on it.
Yeah.
And so what I was trying to do was trying to give some input so that she wouldn't be overusing that group of muscles.
Yes.
And she could access, her profundus and the other long flexors of her hands a little bit better. So so that helped. So then we talked about what can we do with your shoulder if this is protected a little, if this is a little bit better. So that was the thing. It was like, okay, so you're going to have to approach the body in a couple of different ways. And so I said, I realized that you kind of have your choreography and what you do, but how can we create some creativity here for you to be able to work and get this to settle down? So we did. One of it was get on the other side of the table.
Right.
Start giving the left side a little more work to alleviate the right side. She has all of the, it's one of those things. We have all of our tips and our tricks, and then for whatever reason, we quit using them.
We're creatures of habit.
I know,
really
so, we were trying to problem solve. What is she going to do about stretching the leg? And I said, you have a canvas strap, right? She goes, yes. And it's like, and she goes, oh, I know. I should just get them to do it. It's like, yes. Save yourself and then teach them to do it at home, whatever, but, so it was just the rest of the session was basically problem solving, how to kind of get by these particular things that really bothered her, to use a tool or an instrument, even if it's just a ball to work on some of the deep tissue stuff. You don't have to always dig in with your thumb. What can you think of that you can use? And what was interesting, she said that, she says, I have a whole roll of Dyson, that, she could put it right on them and flat palm it and work that deep kinetic. She just never thinks about doing it.
No, for sure. I mean, we've all had that. I mean, I'm looking at my thenar eminence. I'm a lefty, but I do a lot with my right hand, and it's significantly hypertrophied. I've had issues over the years, and I treat differently, because of it now. But it's, you almost wonder with somebody, and I've had shoulder issues on that same side, right? And you almost wonder the amount of compression in her GH joint, her glenohumeral up in, by her clavicle, and that whole area in the upper thorax probably had a lot of compression in there, right? And so just as a result of her changing her movement pattern.
And for those of you who are in the audience trying to figure this out with your hand, all you need to do is take your thenar eminence and the thenar eminence, leave your thumb out of it, just the thenar eminence, and squeeze your thenar eminence to your hypothenar eminence, and you'll see the position that the thumb gets in.
So you take your left hand, put it on your thenar. I'm using.
Just do it like this.
It's almost like a glove, like your.
Yeah, but leave the thumb out. So just squeeze the bottom part of your hand
with the other hand. Yeah.
Just like this.
Got it. Yes. Yes.
And then now you can do it without it, and you'll feel how that joint gets pulled into extension. Yeah. And gets compressed.
Yes.
And that's what happens when we do that.
Yeah.
Because we're not opening the hand out. We're allowing it to collapse in and using the strength of those two thenar and hypothenar eminences to give us the power. And we're not using the rest of the hand. And so the shoulder was lifting up so that her hand would get in a different position. Rather than opening her hand out. So the exercise program for her. Obviously we need to do some shoulder exercise and to get a little strength and power around the scapula. But she couldn't tolerate getting on her hands and knees because it hurt her wrist and it got her into a funny position. So we did the trick of, using like a yoga block and allowing her, so she could weight bear onto the block and her fingers could drape over the end of the block. just to change the position, get her out of full wrist extension, and get her out of, where she's extending and compressing the base of her thumb and as well, so that she could start to work on that. And I used that on purpose because I wanted her to, while she was like had her hands on the block, then we worked on opening the hands out, much like what we do with the feet. You're standing on the feet and you're getting set over the 3 points of your feet, and then the long toes, right? We open out the toes, and same thing here. Use that opportunity for her to come out of compression and open those hands out while she was in weight bearing, so that she could learn to actually isolate and do that again. But she was on the hypo and thenar eminences, so those were being inhibited because she was weight bearing onto those and not onto her joints.
Susan, in standing, was she more biased to the one side, or was she fairly centered?
Not really. Yeah,
she's fairly centered. Okay.
Yeah. It wasn't like those kinds of drivers that you would expect to see with the thorax over to the side, or limitation of the head. It all just seemed to be contained into this, actually lower part of her limb, and their shoulder was paying the price for it. Yeah. So we started with that, and kind of, I started her standing and weight bearing on the blocks because I didn't want to flare her up. I wanted to actually find some exercises she could do in the moment while she's at work. And so we played with this, and we decided that, she actually had a couple of blocks that, she puts under feet and stuff like that she could use at work. And we used that to kind of like actually massage the thenar eminence, so she could lean on it and kind of massage her own thenar eminence. Nice. But then her exercise was to lift her fingers up and open them out, like she was going to reach down and grab a ball or reach out and grab a glass. So we wanted to maintain that roundness of the fingers. We just wanted them to like be able to open up.
Still on her hands and knees?
So standing with her hands on the blocks. Yeah.
On the wall. Standing with hands on the blocks. Got it.
Blocks were on the bed.
Got it. Okay.
So she was
leaning forward.
Yes. Exactly. And then we progressed to where she could, lean down a little more and lean down a little more, and eventually get on the ground. And then eventually we were able to, as we were working for, with extension exercises and things like that, she was able to get her hands onto the ground, and she was able to do it without collapsing in at her thumb joints, which was important.
Got it.
So she had some oomph to her hands.
Got it.
Instead of just the intrinsic muscles working like crazy, she had some like good oomph to the long tendons.
Yeah. And
as well.
Yeah. And Susan, the blocks were yoga blocks again, or just regular?
Yeah, they could be yoga blocks. Thick. Yeah. They just so that, whatever you're leaning on, you're weight bearing right onto the thenar and the hypothenar eminence, and you can control wrist extension. So you're coming out of the full, it's like sitting up on a bar stool versus sitting down in a chair. So we're taking the hands as they would be on the ground, on any surface, and we're just lifting it up from the proximal end of the hand up. So that, she's weight bearing there, and she doesn't have to be in full extension.
Yes.
And also to alleviate some of the compression she gets in full extension with, with the work she was doing. And then we started working on, the phalanx position to start increasing, wrist extension and finger extension and all of that kind of good stuff. You start in that prayer position, and then you just start lifting your elbows up, to get the, and she could control that pretty nicely. That was also a nice reset exercise.
I was just going to say, because that just touches that barrier and backs off. Oh, I love it.
And everybody should do this, especially if you're treating, because
I know
when you put your hands together and you just slightly lift the elbows up, you'll feel the stiffness and maybe even some pain in that thenar eminence. Yeah. It's amazing how much happens there.
It's very true.
And you can compress, if you compress with your elbows down and you're less extension, you can still probably feel it, but it's not as bad. So you can kind of work with that to again, change that up and reset that. So we did a lot of those types of things. And then, she, one of the biggest exercises I wanted for her was not squeezing digits. She had strong, she could, she had nice tip to tip squeeze pressure. But what I really wanted her was to develop was that round hand again. So we used a bigger, like not the green Franklin ball, but the bigger orange one.
I was just going to say that. I can't believe it. I literally was thinking the same thing. Yeah.
And so that was her thing, was to, like, whenever she could, like, she had it by her, chair. If she was watching TV, she'd just grab hold of it and just kind of hold it and do easy squeeses. And the whole idea was open up your hands all the way around, so that it could accommodate as much of the ball as possible.
Yes.
To kind of retrain that. And then she could hold the ball and move her wrist around in all different directions. And, so she had that as kind of a nice tool to start strengthening her hand in different positions. We talked a little bit about, grabbing a glass, can you do it with your wrist more neutral, and instead of like dropping into extension to grab a glass? So, just little tweaks, things to just become aware of for her to kind of understand that she can get out of, if we can give her joints variance and give the muscle control pattern variance, that she's not going to be just collapsing or caving into those joints every time she uses her hands on that side. And so those were all fun things we did. And then finally, this is a trick I learned from my favorite OT friends, for just mobilizing the CMC joint, is with your left hand, grab your right thumb. And then put them on top of your head. And then your right hand, stick your fingers up in the air and wave them back and forth and hold on to the thumb. So it's the hand mobilizing the thumb rather than mobilizing your thumb.
Oh, I like that.
Yeah, it's great, isn't it?
Yeah.
One of the best things.
It's like you're waving high.
I know, it's as silly as it can be, but it's a great way to stabilize, the rest of the surfaces, and let the hand mobilize the thumb, versus everybody's always grabbing fingers and pulling on fingers. This is nice because it's now, it's like the closed chain versus open chain.
Exactly.
I can bend my hip, or I can bend over, so just having a different way to do it. And that was a lovely reset for her.
That's wonderful.
Really, really, really like that one too. So they were all accessible. I wanted things that would be super accessible in the moment.
Yes. In between patients.
For her at work. But I think that the main part of this story to take home is that, sometimes it walks like a duck and quacks like a duck, but it's not really a duck.
Right.
So in this case, there was a duck there. She had real shoulder pain, and it was mechanical. You could see it. You could reproduce it. But the reason for it was not the reason for it was being driven by something that had been going on in the hand for a long time.
Yes. And it's so interesting. So the focus of her program was really to get more input from the other digits.
Yes.
Like the other fingers, and get her to get more of a better grip, quote unquote, with her second, third, fourth fingers, right? And the pinky.
Absolutely. And to open her hands out more, and to use the whole hand, and not rely on collapsing into to joints, with your thumbs, just collapsing into extension and compression at that area. So, but the interesting thing is we could have treated her shoulder, and treated her shoulder, and treated her shoulder, and yet it probably wouldn't have gotten better.
Right. If she continued to do the same thing over and over again.
Because she continued to go back. And if she tried to change her shoulder position, it was going to hurt her hand. And then she'd come, so.
It's so interesting, because there's nothing in her story.
Right.
You see people with, at least a bazillion injuries, right? She had zero of that, significant. She didn't have any sort of continuous movement pattern except the occupational one, right? And that's the one that you focused on, right? Because that was the more meaningful one, right? And that was the only one, right? And it's interesting too, because a lot of therapists will see that biceps tendon. They'll see overt clinical signs and symptoms at the shoulder, but take a step back, like you did, and look at the whole person as they move that's their dominant pattern. I mean, we all know that, but I loved the for me, the beauty of this story was like the resets, you know, because we would all benefit from those. I mean, any manual therapist would benefit from those, you know.
Absolutely. Yep.
For me, because I've had both symptoms. I've had thumb pain and I've had shoulder pain. So those are great takeaways for the listeners if you're physical therapists or body workers, right? So I like it. I love it.
Yes. Awesome.
Story.
Okay.
Yeah, we don't do much of the wrist and the hand. So
I know, and it's something that we all have issues with. So anyway, it just kind of came out, I think, as timely. You know, just thinking about grip strength as a sign of lessening health.
Yes.
So we want to keep our grips, you know, we want to keep our grips strong, and we run into bad habits as manual body workers of all kinds. You know, we do, and we need to think about that, because pay the price later on down the road in trying to do the simple things like opening things. And I think one of the coolest things they ask on the hand disability questionnaire, whatever it is, I'd have to look up the exact one, is, you know, difficulty opening doors, difficulty opening jars, difficulty peeling fruit. There's your thumb. How many of you have peeled an orange without using your thumb in that bent DIP extended, you know, CMC, you know, I mean, my goodness gracious, you know, it's like it catches all of the, you know, but all of the little things that we do during the day, you know, start to, you know, stand out. If we're not able to do those, it's a sign of, you know, it means that it's one of the signs that they use it for, you know, like people maybe more disabled. It's a sign of disability. So more prevalent with lack of grip strength.
Yes. That was a great story. Thank you, Susan. Awesome.
You're welcome. Thank you. All right, everybody. Continue having a great summer. And we will see you on the next podcast
next week. Bye.
Bye.